stuff to cover.
Let's do it.
Yeah.
Okay, everyone. Well, introducing Dr. Norman Litchfield. Dr. Litchfield graduated medical school from the James H. Quillen College of Medicine at East Tennessee State University, then completed his adult psychiatry residency at Duke University. Following that, he came over to Boise, yay, and worked at the VA Medical Center as the inpatient psychiatry chief from 2015 to 2021, and then joined as lead psychiatrist on the inpatient consult liaison service at St. Luke's here in Boise. He's been awarded a number of honors, including excellence in teaching, as recognized by University of Washington School of Medicine and Idaho WWAMI students, and also the Dr. Judd Lund Memorial Idaho WWAMI Teacher of the Year. Dr. Litchfield's also published in the Journal of ECT. So without further ado, Dr. Litchfield, thank you for being here.
Cool. Thank you. All right. Well, yeah, thank you to the residency for inviting me to speak. And we're going to be talking about stimulant treatment for adult ADHD today from an addiction medicine perspective. Can everyone see my slides that I'm sharing? Cool. Thank you, Heather. I'm going to try my best to monitor the chat if I can. I'm going to drag it off of the screen. So yeah, if folks have questions along the way, you're welcome to put them into the chat, or also encouraged to come off mute, turn on your camera and interrupt at will. There will be some audience participation opportunities too, but don't feel like you're put on the spot or having to interact. But yeah, we're gonna just dive right in. All right, so let's see here. So I do not have any disclosures, but this talk was inspired by a talk that I was recently attended at the annual meeting of the American Addiction Medicine Society in Washington, D.C. back in April. And so I have their disclosures here as well. Dr. Moran, one of the presenters there, does receive funding for her research on risk of psychosis, mania, and stimulant use. We've got some of her research that I'll be sharing here in a bit. But for today, the main thing I was hoping to address today is an increased awareness for the complexity involved in accurately diagnosing ADHD in adults. We're going to review the evidence for treatment of adult ADHD with stimulant medication alone and comorbid with a substance use disorder, and then review the harms of treating adult ADHD with stimulant medication. All right, so why this topic? So certainly, in my experience, I've been primarily a hospital-based psychiatrist in my time at VA and now at St. Luke's, and did not start up an outpatient clinic really until I began my role here at St. Luke's in earnest a couple years ago, where I inherited some patients with ADHD on stimulant medication, and certainly have seen a lot of folks coming in asking for evaluations for ADHD and stimulant medication. And my understanding is that that experience is pretty similar to others' experience across the nation. We've seen an increase in the rates of stimulant prescribing and diagnosing of ADHD, 16% pre to post pandemic. And I wanted to take this time to address some of the current concerns that I've seen in my own clinic and practice, but also some of the concerns and trends that we're seeing nationally. So certainly, providers without expertise are increasingly involved in diagnosing and treating ADHD. ADHD disproportionately affects people with addiction, and that leads to this increased risk of developing or contributing to a stimulant use disorder when we're treating these folks with stimulant medications. and leading to an updated warning that the FDA issued back in May, and we'll be talking a little bit more about that. Also, it's important to understand that the entire history of ADHD and treatment has been heavily influenced by the pharmaceutical industry from the very beginning. And while we definitely need the pharmaceutical industry to be able to do research and development, there are also major risks when the industry is one of the primary drivers of the research that we have. And then this quote here came from the CDC Morbidity Mortality Weekly Report back in March, after they published a report of the prescribing trends with stimulant medication from 2016 to 2021. In response to that, they noted this: growing recognition of ADHD in adults and increases in prescription stimulants fills raises questions about current ADHD adult care. Development of clinical recommendations for diagnosing and managing adult ADHD could help guide safe and appropriate stimulant prescribing. All right. So what is adult ADHD? To begin with, ADHD is a real illness with real morbidity and substantial cost to society. The prevalence of adult ADHD is somewhat up for debate, but according to the DSM-3, maybe up to 7% of adults have ADHD, and that prevalence is much higher in someone with a substance use disorder. ADHD is associated with an increase in unemployment, accidents, mortality, paired relationships, and an increased risk of substance use disorders. Like me, you may have been taught that treatment of childhood ADHD prevents developing addiction in adulthood, but actually the evidence for that is mixed. And if anything, there might actually be evidence that treatment of ADHD during certain periods of the developing brain might convey an increased risk for addiction. So specifically, stimulant treatment of ADHD in the adolescent period may convey an increased risk. That was news to me. I did not know that before preparing for this talk. How is ADHD diagnosed? Many of you already know this. It's a little bit different in adults than kids. 5 symptoms of inattention and 5 symptoms of hyperactivity in kids at 6. And importantly, these symptoms need to be present before the age of 12. They need to be present in at least 2 domains and cause reduced quality of social or vocational life. And also importantly, they need to first rule out that these symptoms are related to any other mental disorder or substance use disorder. Specifiers listed there for combined presentation. So this is what we consider ADHD, or a predominantly inattentive presentation, commonly known as ADD, or predominantly hyperactive impulsive presentation, where people are only meeting the 5 symptoms of hyperactivity and not the 5 of inattention. This according to the DSM-5 TR that just was published within the last couple of years. So adult ADHD, is this an extension of childhood ADHD, or is it its own thing, separate from childhood ADHD, or is it an undiagnosed comorbidity? So there are actually a few studies out there that have looked at this question, and the rates of persisting into adulthood vary widely. So estimates of persistence into adulthood range from 5% up to 50%. Many of these prevalence rates of adult ADHD are based primarily on self-reported symptom scales, which we'll talk about more, but is really not a valid way of diagnosing or assessing prevalence. But the 3 studies shared here, and I know this is a really busy slide, try to get at this question of adult ADHD prevalence. So the first, the New Zealand cohort, published in 2015. This is a cohort of about 1,000 individuals born in 1972 or 1973, followed until age 38, and they had extensive evaluations throughout their lifetime, including neuropsych assessments. And from that study, the childhood prevalence of ADHD was about 6%. Adult prevalence was about 3%. That's consistent with the numbers that we would expect. However, the study found there was virtually no overlap. So kids with ADHD, 95% of the time grew up to no longer meet criteria for ADHD as adults. And those adults, those 6% of adults who did have ADHD, almost all of them did not have evidence of childhood ADHD. So this is a surprising finding, and supports that persistent rate of 5% of kids may go on to um, continue to have ADHD into adulthood. Then there are two other studies that have looked at this question, and both of these are comparison cohort studies of ADHD where there were kids with ADHD identified in one cohort and then kids without ADHD identified in the comparison cohort. And these studies looked back at those comparison cohorts as they were followed throughout their lifetime. Of those kids, how many of them went on to develop ADHD as adults? And so in the first one, this is the Sibley 2018 study, looked at the MTA. And if you're familiar with ADHD, you might be familiar with the MTA study, the multimodal treatment of ADHD. First came out, I believe, in the early 2000s. I could talk a lot more about the MTA study, but here we're just going to look at the comparison cohort. There were 239 individuals identified as kids who did not have ADHD, followed until they were 25. 95% of those who screened positive for adult ADHD were excluded on follow-up evaluation. And the most common reason for excluding those who screened positive was due to the effects of a substance or substance use disorder. And then the Berkeley Girls with ADHD longitudinal study, the Berkeley Gals study, Ahmad et al. In 2019 went back again looking at the comparison cohort without ADHD as kids, 87 women followed for 16 years. 17 of those women were found to meet criteria for ADHD as adults. And only one of those, 1 out of 17, on further evaluation was thought to have symptoms that could not be attributed to a substance use disorder or another mental health condition. As a result of this, the DSM-5 TR in 2022, citing the Sibley study above, states ADHD begins in childhood. When symptoms of what appears to be ADHD first occur after age 13, they are more likely to be explained by another mental disorder or to represent the effects of substance use. And I really want to try to hammer this home that according to our diagnostic manual, ADHD is a childhood disorder that starts in childhood. And if someone does not have evidence of childhood ADHD and you're seeing them as an adult for treatment of ADHD, you are most likely not treating ADHD. So there's this question of, is ADHD over or underdiagnosed? And if you're like me, you learned in school and heard throughout the years that it's both. ADHD is both over and underdiagnosed. However, you may not know, like I didn't know, that that catchphrase was first used by the ADHD lobby and big pharma lobby beginning in the 1990s in response to rising prevalence rates. The pharmaceutical companies marketing stimulant medications were very worried that news would get out that ADHD is being overdiagnosed. And so they vetted how they were going to respond to this, and they came up with this phrase, ADHD is over and underdiagnosed. And sure, there's some data to support that ADHD is underdiagnosed, but the evidence for overdiagnosis is very clear. Beginning with the broadening of criteria. So higher prevalence rates have been marked over time as the criteria of ADHD has been broadened from DSM-4 to 5, from 3 to 4. And that broadening of prevalence rates coincides with a broadening of prescriptions for stimulant medications. There's also clear evidence that stimulant treatment for ADHD is less efficacious in folks with milder symptoms. Children born earlier in the school year are more likely to be diagnosed with ADHD, again, suggesting that If the only reason they're getting diagnosed is because they're born earlier in the school year, is that an accurate diagnosis? And then there are clear discrepancies between the US prevalence rates and international prevalence rates. The high degree of symptom overlap with substance use disorders and other psychiatric conditions is thought to be the major cause of misdiagnosis and overdiagnosis. Next, so malingering is a real consideration in treating adult ADHD. There is a very high prevalence of individuals exaggerating symptoms. In one study, as high as 22% of adults presenting for stimulant treatment of ADHD have malingering. It's very easy to fake symptoms on a patient report symptom rating scale. There's a study of undergraduates coached about ADHD via internet compared with students with ADHD. Those coached to fake ADHD symptoms, they met the criteria based on these checklists, and symptom ratings, self-rating scales could not distinguish the two. Multiple other studies have corroborated findings that using symptom checklists alone, you're unable to distinguish between those who are fabricating symptoms and those with true ADHD. So why is adult ADHD diagnosis difficult? Well, uh, we've been talking about checklists are usually positive, and it's sometimes hard to understand what is disordered and what is normal when people are screening positive on checklists. There's also myriad causes of inattention, other psychiatric disorders, depression, anxiety, active substance use, PTSD, severe persistent mental illness, lifestyle. Many of my patients seeking stimulants for ADHD have significantly disruptive sleep cycles, a lot of stress going on in their life, and it's hard to tease out to what degree is their stress and disruptive sleep related to an underlying ADHD, or to what degree is their inattentiveness related to their lifestyle. Multitasking is pervasive in our society and leads to inattention. Also, I wanted to just highlight cannabis use specifically has been shown to lead to inattention by itself outside of a cannabis use disorder, um, and is an important thing to rule out when thinking about the diagnosis of ADHD. Also, there's no diagnostic test. I have people telling me they've been tested for ADHD and they've tested positive. Well, there's no such thing as an ADHD test. The diagnosis requires a comprehensive evaluation, and that is difficult to do. People craving substances, they may feel convinced of the diagnosis and press hard for treatment. And unfortunately, it is a very popular diagnosis on TikTok, social media, and there's this hypochondriasis effect. So I share this slide not to overwhelm you, but to suggest that to drive home that treating and addressing ADHD is complex, but it can be done. And there are good ways to go about this in um, standardized assessments. This is one example of a proposal for an algorithm for addressing ADHD. It's intended specifically for primary care, but published by the Harvard Review of Psychiatry in 2016. And I think it's an outstanding review and an outstanding resource for those of us treating ADHD in outpatient clinic settings. You'll notice on there, many of those boxes say refer to psychiatry. And so it's important to understand that we in psychiatry are expected to be the experts here. We are expected to be able to tease apart when someone is having comorbid symptoms, how much of these symptoms are related to the comorbid issue versus ADHD or another substance use or lifestyle issues. So it's a real kind of call to action for me. Time check. I think we're doing okay. I don't see any questions, but we're going to switch gears here and take time for a quick case. So this is the case of Fidgety Phil. Dr. Harris suggested I might get some blowback for that name, but there's a history to that name that I'm not going to go into right now. But folks can ask later. Okay, so Phil, 29-year-old man with opioid use disorder, recently stabilized on Suboxone. He presents to your clinic for an ADHD assessment. He says staff at his IOP, where he's currently in treatment, tell him he frequently interrupts and can't sit still in groups. He reports a diagnosis of ADHD made at age 14, but parents didn't believe in meds, so he was never medicated. He does say he has a successful trial of Vyvanse with another doctor last year, but they would not continue to prescribe it because he was using. He's unemployed, lives with his girlfriend, who's a nurse, and their 3-year-old daughter. So, any ideas? What else do you want to know before you make a diagnosis of ADHD or start this gentleman on stimulant treatment? Hearing nothing, I'm going to move on, but feel free to chime in if anyone has any.
Laura has something.
Oh
Oh,
yeah,
I guess I
please.
have. I would want to know just more globally, like why now? What is making him present to care now for ADHD and presumably a stimulant prescription?
Yeah, exactly. What's going on now? He's telling you a little bit about he's got some symptoms that are disrupting his IOP. He's getting this feedback from peers and treatment providers at the IOP. But yeah, what else is going on right now? Dr. Fox says she'd like to know more about those childhood symptoms, substance use history from Dr. Sue. Excellent. Yes. So you want to do a diagnostic assessment. I want to give each of you permission to slow things down. When you are doing ADHD assessments, you do not have to feel rushed. You may feel rushed, but you can take that as a cue to slow things down. Set expectations at the first visit that you're not going to prescribe stimulant medications at that visit. This is going to be an assessment. Um, that's not always possible. Sometimes you do need to make a decision about medications at that first visit. But again, I really encourage each of you to try to slow things down. Most of the time, people can wait. Um, so, you know, you could consider some assessment tools like a symptom checklist, but again, be very careful about use there. I only use those assessment tools once I've made the diagnosis to chart symptoms over time. Definitely want to try to get collateral. Um, if we can, let's get collateral from parents about childhood, partners about current dysfunction, coworkers, clinicians. Quick note here about inheriting patients. A lot of us inherit patients on medications that we never started. Um, and it's important to do your own homework and not get caught up in diagnostic inertia that, oh, this person has a history of ADHD, therefore they have ADHD, and look closely at comorbidities. Okay, so what would you do? Number one, ask Phil to complete a quick screening tool where he endorses all symptoms of ADHD, and then you decide to put him back on Vyvanse 70 and have him return in a month. Or do you conduct a thorough assessment for ADHD as well as other psych comorbidities, get a urine tox screen, check his PDMP, obtain collateral from the girlfriend and past prescribers, suggest some behavioral modifications, maybe start guanfacine? So, all right, this is kind of a loaded question, but I think everyone's going to say, let's go with number two. So after thorough assessment and some guanfacine, Phil returns 2 weeks later reporting, yeah, he's able to sit still a little better, feel a little calmer. Inattention continues to interfere with his engagement at IOP and life at home. Substance use continues to stabilize. He's in early recovery, continues in IOP. His relationships are improving. He's getting serial negative tox screens. You get records from his prior doc that confirm his story that he was on Vyvanse and it was stopped after opioids were came positive on his tox screen. You speak to his partner who says, yep, he doesn't really complete chores around the house. He's got poor follow through and he's frequently distracted in conversations. At this point, you sit down and talk with Phil about risks and benefits and decide, all right, we're going to try retrial of a stimulant medication to address some of the concerns that he continues to have in his life with Vyvanse at 30 milligrams. Cool. We're going to come back to some cases in a bit, but now we're going to switch gears just a little bit and take a look at the evidence base for stimulant treatment of adult ADHD. So, conflicts of interest are the norm when looking at the data for stimulant treatment of ADHD in kids and adults. Conflicts of interest are the rule, not the exception. I would say most prominent researchers in ADHD have received funding from pharmaceutical companies marketing prescription stimulants. And this includes the researchers who are involved in large studies that were intended to be separate from pharmacy influence, including the MTA study. There was a Cochrane review on methylphenidate in 2016 that had to be retracted as a result of conflict of interest. There's actually been multiple legislative investigations and Senate hearings, House hearings, as a result of concerns about pharmacy industry influence, most recently in 2008. I skimmed right over a book, ADHD Nation, that some of this information is from, and it's earlier in the slides. I highly recommend it for anyone who's interested. Not just prominent researchers, but many, if not most, of the patient family advocacy groups receive funding from pharmaceutical companies. And this mirrors the opioid pharmacy influence, where the opioid pharmaceuticals would fund patient advocacy groups around raising awareness of things like chronic pain. Panels responsible for widening the definition of ADHD and allowing adult ADHD diagnoses. Also, most members had ties to industry. And there's been immense marketing dollars devoted to us, practicing physicians. 25% of all industry payments to pediatricians in 2014 were for 3 stimulant medications. 1 in 18 physicians receive marketing from stimulant pharmaceutical companies. $7 billion for Vyvanse between 2014 and 2018. So let's take a step back. We are not funded by pharma. If we wanted to design a trial of ADHD treatment, what would we do? How would we design that trial? Well, first, we take a look at why do we treat adult ADHD? Well, we treat it for improvement in functioning, reduction of mental health symptoms. We treat for improved employment outcomes, reduced accidents, injuries, improved relationship outcomes, reduce risk of addiction, support recovery. There's a question mark there because some of the data, again, is a little bit mixed about that. So if those are the reasons why we treat ADHD, we would want to design a trial that looks at those type of outcomes. We would want to look at, maybe symptom scales of ADHD, but we've already learned that it's very easy for someone to feign symptoms on a patient report scale. So we'd want to see psychiatric assessments by someone other than the patient reporting improvement too. We'd want to take a look at retention and care, employment history, traffic safety data, social history data, substance use outcomes, and how long would our trial need to be to see these outcomes? Guesstimates out there. What would people say? What would we want to take a look at? For how long? I would say at least 6 months, if not a year, so that we can know that these outcomes we're given enough time for these outcomes to show up with our treatment. Let's keep that in mind as we take a look at the evidence for stimulants. So there's been 3 Cochrane reviews for stimulants that we're going to take a look at. The first here is the review of amphetamines in adults. Again, I'm just focusing our review on adults here. And this one was published in 2018. So 19 randomized controlled trials, 18 in the US, 10 multi-site. The mean study length was 5.3 weeks, a range of 1 week to 20 weeks. All were placebo-controlled. 3 included an active comparator, guanfacine, modafinil, and paroxetine. 16 of the 19 were funded by pharma. 1 was publicly funded, and 2 did not disclose their funding source. The outcomes, so average age 35, 57% men, mostly white. There's very, very little of the data that we have on minorities. And very few of the studies included patients with substance use disorders. Outcomes reviewed by the Cochrane review were severity of ADHD symptoms, retention and treatment, and adverse events. And the results of the Cochrane review found low to very low quality of data as a result of lack of blinding, attrition, selection reporting without a priori outcomes, crossover without washout phases, short duration baseline wellness. Often the outcomes were, with regard to symptom severity, were related to patient-rated scales or physician clinical global impression scales. There was no difference for amphetamine versus guanfacine or modafinil in those comparison trials. No effect of stimulants on retention, and there was an increased association with stimulants for adverse effect related withdrawal from treatment. So that's the Cochrane review on amphetamines for adults. Low to very low quality data. What about methylphenidate? So in 2021 and 2022, there were two Cochrane reviews, one for methylphenidate immediate release and the other for methylphenidate OROS, which is Concerta. So similar limitations here that this Cochrane review found with the data: short duration, high risk of bias, and adverse effects were poorly assessed. And the Cochrane review found almost all have notable concerns related to sources of funding and conflicts of interest. Most did not include comorbid psychiatric conditions. And for the OROS, there's no effect on missed days of work, and only a small to moderate effect on self-rated ADHD symptoms. So this is Concerta for adult ADHD, only a small to moderate effect on patient self-reported symptoms improvement. For the immediate release methylphenidate, there was a direct comparison with lithium that found no difference between methylphenidate and lithium for treatment of adult ADHD. So what about head-to-head comparisons? Well, there's not been a lot of head-to-head comparisons, but the ones that have been done found no significant difference when comparing stimulant medication to active comparators for treatment of adult ADHD, and they're listed here. Not going to go into a lot of detail, but the comparators were atomoxetine and paroxetine. What about functional outcomes? What does the data show us about functional outcomes with stimulant treatment of adult ADHD? So in observational studies, stimulant prescriptions are associated with decreasing car accidents, decreased unemployment in women, but not men. And there's this meta-analysis showing modest effect on short-term abstinence from cocaine with high-dose amphetamines. What about what do stimulants not do? So we do have some data out there about what stimulant medication does not do. They do not improve learning of material. This is from children, data out of kids, but children randomized to methylphenidate had markedly improved classroom behavior, but no improvement in learning, which kind of calls into question, what are we treating? Are we treating the teacher's distress at the patient's behavior, our patient's behavior, the student's behavior, or are we treating a disorder that's causing dysfunction in someone's ability to learn in the classroom? Stimulants also do not substantially improve performance on neuropsych testing. So college students in a randomized control trial crossover of Adderall versus placebo, there was no change, no significant difference on neuropsych testing. Quick asterisk about neuropsych testing: it is not recommended in diagnosing ADHD. There are very specific reasons why you might want to recommend neuropsych testing, but as a general rule, it is not recommended to refer your patients for neuropsych testing to make a diagnosis of ADHD, because neuropsych testing cannot do that. There is no neuropsych test for ADHD, once again. And then stimulants do not substantially improve GPA. In studies with good adherence, there might be about a 0.11 point improvement in GPA. So for us clinically, what do we make of this? Well, it suggests to me that when we do make a diagnosis of adult ADHD and we decide to treat with stimulants, it's going to be really important that we track functional outcomes in the clinic, asking questions like, in what ways are you not functioning well now, that we can track together to understand if this medication is helping. So employment, do you have a job? What's your feedback like from your supervisors? How are things going at work? Home life, managing responsibilities at home, housework, projects, appointments, parenting, social life. How are they doing engaging with loved ones? Okay, we're going to take another case. So this is the case of the comorbidity conundrum. Connie, she's a 39-year-old woman with opioid use disorder on Suboxone. Prior to treatment, she also used cocaine regularly, which she says helped her, but has been avoiding cocaine while on probation. She now presents asking about medication for ADHD. She has a history of childhood trauma, and for a period in childhood, she was treated with stimulants. She's working full-time at a local grocery distributor and feels unfocused at her work. Sleep is impaired by nightmares that relate to past trauma, and she uses cannabis dabs to help with sleep and anxiety. What else do you want to know? We can similar things to the last time. All right. So again, treatment approach, slowing things down, setting realistic expectations. Treatment does not turn someone into a person without ADHD. ADHD is thought to be childhood onset, lifelong neurodevelopmental issue that someone's going to either learn to manage throughout their lifetime or learn how to get by with these difficulties. And treatment doesn't change that. It doesn't make you not have ADHD anymore. Also, the goal of treatment is not to feel something. I can't tell you how many times I've had people come back after we start stimulant medication and they tell me, I didn't feel anything with that dose. And it kind of in the back of my mind, I'm like, well, that's actually kind of the goal of treatment is not to feel something. Tell me about how you're doing, how you're functioning in your life and what kind of things are going on. You can validate and not medicate. That's hard for me to do. But yeah, Dr. Harris has some great ways of being able to say no while validating. Also, important to understand when treating patients with a co-occurring or history of substance use disorders, foundation of recovery, kind of understanding what part of the brain is in the driver's seat or how much of their seeking treatment at this point may be related to undermanaged, underrecognized symptoms of a substance use disorder or another mental health condition that they're engaging in experiential avoidance through their current engagement. Comorbidities, consider non-stimulant options first. Some cannabis considerations, and I've listed some sources there about cannabis and inattention. So there's a clear connection between cannabis use and inattention, even in the absence of a cannabis use disorder. And in general, the recommendation is that before we make the diagnosis and treat ADHD, we should make sure that someone's not on cannabis. And getting some release of information to coordinate care with other folks. All right, so what would we do? Number one, advise Connie that cannabis and PTSD are likely to be significantly contributing to her symptoms and prioritize those issues to target. Number two, advise Connie, that because of prior cocaine use, you're concerned about increased risk of potentially addictive medication and would not prescribe stimulants for her. Hopefully most folks here would go with number one, but let's see what happens with number two. So you advise Connie that you would not prescribe stimulants because of her prior cocaine use. She becomes super angry, accusing you of not wanting to help because of her past, and she storms out. I don't know about you, but this has happened to me. She later apologizes, insightfully reports her reaction was reminiscent of emotions expressed during past trauma, particularly with regard to authority figures. She continues in treatment, maintaining abstinence from opioids over the next year, but her cannabis use continues to increase. And she tests positive for amphetamines and cocaine several times over that year. So the end, sad face. The reason for the end, sad face there is that we have not addressed that trauma history. We have not addressed other issues here. All we've said is, sorry, no stimulants for you because of your cocaine use. But what if you advise Connie that cannabis and PTSD symptoms are likely contributing to her symptoms? Maybe in a perfect world, she stops using cannabis and starts individual therapy. Prescribed prazosin at nighttime for sleep improves. She does feel that she gets distracted at work, but continues to hold a job, and her supervisor reports she's a great worker. She still thinks stimulant may help her, but also understands this may be a form of craving. As time goes on, she becomes more rooted in recovery, noting improvement in functioning and clarity of mind without cannabis, and eventually she also comes to the conclusion that stimulants aren't worth the risk for her. What about that case of Phil? So what about just going ahead and giving him the symptom rating scales? He scores everything positive, start him on Vyvanse and have him return in a month. Well, he comes back, he says that med works great. You see him every month. After a while, he calls to request refill a little early. He says he spilled his capsules down the drain while opening the bottle. This happens with some frequency. You ask him to come in for a urine drug test that day, but he can't get in for another week. At that appointment, his next appointment, he's guarded, withdrawn. At the end of the visit, he shows you images on his phone. It's proof that there's an infrared camera. People have been hiding in the walls of his house. He believes the FBI is monitoring him. I think we probably all have been in situations where maybe in spite of our best efforts to provide safe, effective care to patients, they end up with side effects. And in this case, stimulant medications, stimulant treatment of adult ADHD can come with significant risk and harms. So let's take a look at some of those. What are the harms associated with stimulant treatment of adult ADHD? So certainly there's risk of misuse, developing a substance use disorder, diversion. There's this risk of psychosis, mania, cardiovascular risk, sleep concerns, growth suppression, mainly in kids, appetite suppression, and tics and movement disorders. I put an asterisk there by appetite suppression because it's interesting that, again, this data comes from the child data that kids treated with ADHD may actually have increased weight as adults compared to those not treated. What outcome data would allow us to evaluate this risk? So we'd want to see things about toxicology testing, substance use outcomes, maybe PDMP monitoring outcomes, ER visits, psychiatric hospitalizations, cardiovascular surrogates, sleep data, weight, and once again, how long would we want to see a trial to assess for these outcomes? Well, we'd want a decent period of time, right? So what is the quality of the data on harms with stimulant treatment? Well, one of the main meta-analysis that we have comes from Lancet Psychiatry in 2018. This included 51 adult trials and 81 child trials. It excluded high doses. Interesting. It's an RCT looking at risks that excludes high doses of medications. Tolerability was measured by study withdrawal due to adverse effects. The authors themselves acknowledged a lack of long-term safety data when they took a look at the data that they collected for this meta-analysis. This meta-analysis was specifically criticized in the editorials at the time by peers due to lack of inclusion of important adverse effects like sleep, headache, loss of appetite. Interestingly, though, those editorials did not criticize it for the exclusion of people with substance use disorders. Neither in the editorials nor the author's plan to address the editorials did anyone bring up risk for substance use disorders. This is in 2018. And that lack of attention to risk of addiction and substance use disorders is once again parallels what happened with the opioid epidemic. So this is a letter to the editor on the left, published in 1980 in the New England Journal of Medicine, where Jane Porter and Herschel Jick looked at 39,000 hospitalized patients who were receiving, 11,882 received at least one narcotic prescription. And they say out of that, there were only 4 cases of reasonably well-documented addiction in patients who had no history of addiction. And they conclude from that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. That's the extent of this article, this letter to the editor. This article, you can see on the right, was cited extensively in the next 37 years. And you see in the dark blue, those are the citations that affirm the findings of this letter to the editor, stating that there's no risk of developing addiction with opioid treatment in medical patients with no history of addiction. The light blue is other. The middle is the studies that negate that when they when they when they cited this. So just showing how the data that we have on opioids was clearly blind to the risks, even well into the opioid crisis that began in the early 2000s. And we continue to have folks cite this letter to the editor as evidence. We see that same thing in the stimulant medication trials. Moving on, what quality of data do we have about the harms for stimulants? So this is a table looking at the comparative quality of data on harms for FDA approval of fluticasone, and stimulant medications. And the general recommendations come from the ICH guidelines, the International Conference on the Harmonization of Technical Requirements for Registration of Pharmaceuticals for Human Use. So this is a international society that's come up with these guidelines for what type of data is sufficient to show that a new medication is safe for human use. And the general recommendations for short-term studies want to see at least 300, 600 patients for more than 6 months. Long-term post-marketing data, we want to see at least 100 patients for over a year. Fluticasone, to get FDA approval, they had 1,000 patients, and the average study length was 12 to 16 weeks. For the long-term post-marketing data, they had 500 patients in a 1-year study. For stimulant medications, 20 stimulant drugs, the median number of patients was 70. The median duration was 4 weeks. 11 of those drugs were approved with a total of less than 100 patients, and 5 were approved with less than 4 weeks of data. In long term, FDA required post-marketing studies for 6 drugs, but only 2 of them completed it. Some of the reason for this is that some of these medications were grandfathered in because medications like Dexedrine had been on the market for decades. But still, there is a remarkable lack of data about harms prior to these medications getting approved for treatment of ADHD. What about psychosis? So the risk of new onset psychosis is real. The risk is higher for amphetamines than methylphenidate. And the rate it's not super common, but maybe 1 in 500 to 700 patients. And here's some data for Moran about that increasing prevalence of psychosis with increasing prescription rates. And on the right, unpublished data showing that there is a dose-dependent risk here with amphetamine specifically. Higher doses convey higher risk. Cardiovascular risks. So certainly there's an increased risk for high blood pressure, hypertension, increased heart rate. In observational studies, excluding folks with known history of cardiovascular disease, non-elderly patients, there is no increased risk of serious CV events. But in elderly patients, there is an increased risk. And that risk is higher in the first 30 days. What about mortality and overdose? So as off-label prescribing in adults is rising, there is an associated increase in all-cause mortality compared to on-label prescribing for stimulants. Noting some unclear reasons for this, but comorbid psych disorders are a common reason for off-label. Just a note here that Vyvanse is approved for binge eating disorder. There's a really interesting story about how that came to be in that ADHD Nation book that I mentioned earlier. In an observational study of people on buprenorphine for opioid use disorder, prescribed stimulant therapy, stimulants were associated with a 19% increased chance of non-fatal overdose and a 36% increased rate of treatment retention. That study only included patients with high adherence to stimulants, though. So getting close to the end here, but I included this slide from the slide talk from ASAM in April. I do think there are definite parallels with the opioid crisis. I don't want to overblow this or overemphasize it, but certainly um, stimulants are a likable medication. They affect the nucleus accumbens and they affect the part of the brain that is involved in developing addictive behaviors. And that's where this started, with a medication that was known to cause addiction, benzodrine. And then the pharmacy companies, through their influence, got the rest of us involved to expand the target population, expand the diagnosis. And the evidence for treatment has been heavily influenced by the pharmacy industry in both opioids for chronic pain and in stimulants. And often they're based on subjective outcomes. In addition, both have ignored important safety outcomes, including the risk of substance use disorders. Then there's been a rapid rise in prescribing. We definitely have seen that in stimulants. Higher acceptable doses and the development of non-addictive formulations. So lisdexamfetamine, 5-ants, thought to be non-addictive. And sure enough, it is a prodrug that requires activation in the red blood cells to amphetamines. But it is still an amphetamine. Maybe the risk for addiction is lower, suggesting it would be the better alternative to use in someone with a known substance use disorder. But we see that in the opioid crisis too, that the pharmaceutical companies came out with non-addictive formulations while simultaneously denying that their product led to addiction. And then we've seen an increase in stimulant-related overdose deaths, 23% increase in 1 year, 20 to 21. So that slide might have been a little bit overblown, but one thing that is not is this updated FDA black box warning that finally came out in May. And this is taken directly from the FDA website. To address the continuing concerns of misuse, abuse, addiction, and overdose of prescription stimulants, the FDA is requiring updates to black box warning across the entire class of stimulants. There have been folks within psychiatry and addiction medicine who have been calling for this for years. But there has been a successful lobby against it. But now the FDA has finally issued this warning, and they have listed, these are the following items that healthcare professionals should do: assess patients for risk of misuse, abuse, and addiction before prescribing stimulants, counsel patients not to share their prescribed stimulant with anyone else, educate patients and family on serious risk, proper storage, and proper disposal, and regularly reassess and monitor for signs and symptoms of non-medical use, addiction, and diversion, which may be evidenced by more frequent renewal requests. So again, that's taken directly from the FDA warning. All right, wrapping up here. So some key takeaways. Adult ADHD carries significant morbidity. That is true. And there is definitely a higher prevalence among people with substance use disorders. Diagnosing adult ADHD is complex and very time consuming. The evidence for benefit of treatment with stimulants consists of numerous low quality studies without functional outcomes. And just to highlight that, so those Cochrane reviews, when they say there's low quality evidence, what that means is that they cannot with confidence say that we currently have evidence to support that treatment is safe and effective versus non-treatment. The risk of non-stimulant treatment is lower, and benefit may be comparable to stimulants in terms of functional impact. Risks associated with stimulant treatment include misuse, addiction, psychosis, cardiovascular events. The degree of risk has not been adequately assessed with current data. However, I believe, as many other people in the field do, that risk may be mitigated by careful diagnosis and ongoing reassessment and monitoring. All right, so that sums everything up. I'm going to go ahead and place in the chat here the slides. If for anyone who's interested, you're welcome to have access to it. It also has access to all the references. Yeah, thank you for your attention, and be happy to answer any questions.
Yay.
We got one question.
Thanks, Dr. Litchfield. It's great rounds. I was just like trying to follow the numbers closely as you were presenting the like benefits of stimulants, and I took away that it looks like there might be no benefits to stimulants. Is that wrong takeaway? Like it looks weak, and I was trying to get my head around being prescribed stimulants. Part two, I guess, is why would we prescribe stimulants at all? Except maybe we think they might help in some way that we haven't studied in any qualitative, quantitative way.
I think it is wrong to say that the data we have suggests that stimulants are not effective, or that we shouldn't use them. That's certainly not the takeaway. The takeaway is we have very limited data, and the data that we do have is limited first and foremost by bias, but also limited in a lot of other ways. And so the data that we have currently is low quality. We have low quality data to recommend use of stimulants in treatment of adult ADHD. That said, they can still be effective, and they can still be treatment of choice in someone with the correct diagnosis of ADHD with appropriate monitoring for ADHD. But I do think it's important to be clear about the current level of data that we have for this treatment, which is low quality.
I'm just gonna add a plug for that part, because I feel like, in doing this work with a lot of ADHD, it can feel kind of demoralizing at times, kind of knowing the lack of evidence and what you're doing and the controlled substances. So what I've started doing too, like the functional outcomes, is identifying if I'm going to start a stimulant, what are the goals that they're going to progress on as a thing to check up on, which helps some of my kind of my own feelings around it. And then they if they're doing well, and they're, especially at the BSU Student Health Clinic, and then they're like, if they've failed out of 2 colleges and then their GPA is doing better and they're turning in assignments, and there's a functional change. Is it because of the stimulant, or is it because I'm holding a carrot over their head and like having them come in and we'll talk about what they need, like doing some academic counseling kind of a thing. So I don't know.
Yeah.
If anyone has thoughts about that. And then there's the BA folks that have been on it for 20 years. And you're like, I don't even know where to begin with the functional outcome.
Yeah, I think I agree. I think it's the main thing that I am taking away and that I want to try to model in myself is that it's a very difficult diagnosis to make. And even in someone who's like really straightforward, it's time consuming. And you do want to try to set those trackers of functional outcomes and be monitoring for those functional outcomes. And it's very easy to just kind of slip into, all right, I'm going to prescribe a medication. We're going to do some symptom rating scales. I'll see you back and we'll do some refills. But the intent of the FDA black box warning, the intent of this presentation is to recognize that there are risks with this, even in straightforward cases, and we should be aware of those risks and we should be monitoring for those risks. And then when we do have cases where there is comorbidity, psychiatric comorbidity or substance use disorders, that we really ought to be especially mindful and especially careful there and approaching things mindfully. Yeah, and rather than getting caught up in pressures to treat or pressures to do something differently.
Well, thank you.
Thank you.
Thanks.
Yep. I'll drop the slides right away for anyone, and I'm sure the folks can send those out by email too.
Thanks, Dr. Litchfield.
Thank you.
Thanks, Doc.
Thank you.